The next topic we are going to discuss is a very common valve pathology. It's aortic valve stenosis. In case of aortic valve stenosis, the quantification seems relatively straightforward most of the times, but there are some situations where it's not that easy. So let us begin with the principle of aortic stenosis. It's basically what goes in must go out. So what enters the ventricle has to leave the ventricle at some point. And here you can see a normal example. So in this case, you see the systolic blood pressure. It's 120 millimeters of mercury in the ventricle, which is also then displayed in the arterial system, which you can also measure. The diastolic blood pressure in the ventricle is relatively low. So is the pressure in the left atrium. Of course, the diastolic blood pressure in the peripheral arteries is higher. What happens in aortic stenosis? Well, there is aliasing in this area because the valve is very tight. The pressure in the ventricle rises to very high degrees, therefore leading to hypertrophy of the ventricle. Also, the diastolic pressures, of course, rise, and left atrial pressures do so too. So, when aortic stenosis is present, the outflow of the ventricle is blocked. So pressures have to rise to keep a certain degree of blood pressure and stroke volume still going throughout the body. Let me start with a case. It's Greta. Greta enters on a Sunday morning, 9 a.m. in the morning, an emergency department. She's 85 years old and she has dyspnea when she just walks a few steps. So New York Heart Association class 3. She also complains of chest pain when she's walking, while she's walking. Overall, she has no medication and no medical history because, as she states, I have never been to a doctor in my life. Well, what's the problem of Greta? We take a point-of-care ultrasound device and we image a parasternal long-axis view with, in this case and without, color Doppler. What we can appreciate is that the right ventricle is over here, the interventricular septum, the inferolateral wall, the descending aorta, the mitral valve, the anterior and the posterior leaflet, and in the center of the image is the aortic valve. And what you immediately can see is that the aortic valve is severely calcified. When you add color Doppler, you see turbulent flow, but also a little bit of aortic regurgitation. But note that here at the area where the opening should happen is very turbulent flow and also afterwards, after the stenotic part. So what we think the main problem is of Greta is that there's aortic stenosis present. Why is there aortic stenosis? Well, the etiology differs compared to a younger or an older age group. People around or below 70 years, they have very often a bicuspid valve, which is responsible for the stenosis with congenital defect, so to speak. 25% is rheumatic and only 18% have a degenerative aortic stenosis. When we look at the age group above 70 years, almost 50% have a degenerative cause, especially in higher income countries where people age. We will see the degenerative aortic stenosis very frequently. The bicuspid valve and rheumatic heart disease is not that present or prevalent anymore. Why echocardiography then? Well, echocardiography is the key to diagnosis. We need flow and measurements of flow and the visual assessment, which you can both assess with echocardiography. There is also stress echo, so low dose Dobutamin stress echo, which you can additionally use. You can use CT coronary angiography and calcium scoring in case of an unclear situation, but we will talk about that in a later stage. Contrast in echocardiography can also be used not per se for the valve or the flow, but for finding out if there's an additional problem or to quantify left ventricular function. And also strain imaging definitely already has its place in evaluating valve disease. There are several pitfalls you have to remember well. First, the heart rate. We do not want tachy or bradycardic patients. In atrial fibrillation, you have to measure several heartbeats because not automatically the highest measured velocity is the velocity to go. And you also have to avoid hypertension, because hypertension increases afterload or therefore affects the aortic valve and the measurements of the aortic valve. And now let's talk about numbers. When there is no stenosis present, we have a mean pressure gradient below 10 millimeters of mercury. Then you definitely know there is no relevant aortic or no stenosis present at all. An aortic valve area in between 3 to 4 square centimeters, the area we calculate with the continuity equation, then there's also no stenosis present, and the maximal velocity is around 1 meter, so overall 0.5 to 1.5 meters per second. How do we start? Well, of course, we start as always in echocardiography with a parasternal long axis view. If you want to find out more about the parasternal long axis view, click the box and go back to the videos specifically dealing with this topic. Why do we use the parasternal long axis view? Well, we have here the aortic valve in the center of our image, and we have the differentiation in between the right coronary and non-coronary or left coronary cusp seen over here, and we do get a glimpse of the left ventricle and other surrounding structures. Furthermore, you should scan parasternal long axis view with a specific focus on the aortic valve and the LVOT seen over here. With this focus, it's way easier to measure the LVOT, because that's very difficult sometimes, because the LVOT has to be measured directly before the valve, but not too far into the left ventricle. And actually it has to be measured where you place the pulse wave Doppler sample to measure the velocity of the LVOT, so the left ventricular outflow tract, which is located over here. In this more detailed view, again, you can see the right coronary and the non or left coronary cusp. Moving on from the focused view of the parasternal long axis to Erna. Erna had a severe aortic stenosis 5 years ago. So when she was 70, now she's 75, and she was asymptomatic. She even went hiking. She has hypertension and too high blood fatty acids, and she did not go to a follow-up appointment or to an echocardiographic appointment. So what we're evaluating now is Erna, because now she has the problem that she cannot breathe. Why is that? First, we will take a look at the parasternal long axis view with a focused view of the aortic valve. And in this case, we always have to record this focused view, as mentioned earlier, because you can nicely visualize the LVOT, so the left ventricular outflow tract, so that's the cavity of the left ventricle, and this is the left ventricular outflow tract, and the aortic valve. And what we can appreciate is that the aortic valve is severely calcified. So there is only a little bit of movement left seen over here. Overall, it is severely calcified. Well, in this view, you can also measure the LVOT properly. With the focused view, you have really the entire LVOT in at least 2 heartbeats in your field of view. With the LVOT diameter, it's sometimes very difficult because it has a great measurement error if you measure wrong. So if you're off a few millimeters, the measurement of the aortic valve area calculated by the aortic valve area measurement with the continuity equation differs greatly, because 1 millimeter of measurement error equals 0.1 square centimeters. So that is a problem, and very often you cannot see the LVOT so clearly as in this case, because you have to measure inner to inner edge, so from the inside of the LVOT to the inside of the LVOT. You should measure parallel to the aortic valve, and if you are not entirely in the optimal position to visualize the LVOT, it looks a bit blurred, or you do have a little bit of additional tissue seen over here. Also artifacts because of the calcified valve, so it's sometimes very difficult. And you should measure in mid-systole. Mid-systole with this valve, it's very hard to interpret. So you also have to take a look at the ECG and then measure ECG guided and guided with the aortic valve in mid-systole optimally. Now we can ask ourselves with Erna, when we see those images, this is now the normal parasternal long axis view where you have the LV cavity the hypertrophied left ventricle, the right ventricle, the left atrium, the mitral valve, and the aortic valve here in the center. And here the color Doppler information, if this is truly aortic stenosis, and if so, if this is truly a severe aortic stenosis. As she was diagnosed already 5 years before, of course, that is a hint, but also when we only take a look at this image, with this severe calcification, the opening of the aortic valve is severely reduced, and therefore it has to be a relevant aortic stenosis. Given color Doppler information, we do see that there's a little flare showing aortic regurgitation, but here the aliasing and the turbulent flow after the aortic valve to provide visual information that this is truly a relevant aortic stenosis. How can we continue? What is the next view we need? Well, we can move on to a parasternal short axis view. Why a parasternal short axis view? Well, with the parasternal short axis view, you can really differentiate if there are three cusps. The right coronary cusp, always pointing towards the right ventricle, the left coronary cusp pointing towards the left atrium, the non or acoronary cusp pointing towards the interatrial septum. So if you have those three cusps, you can visualize if there is a normal opening present. Here's an example, and you can also take a look at the compact echo course for the parasternal short axis view. For this, here you see the aortic valve with a normal opening. The leaflet or the cusps, they are normal. The surface seen over here is smooth, and there are three. So the right coronary cusp pointing towards the right ventricle, or the RVOT, the left coronary cusp towards the left atrium, and the non-coronary cusp towards the interatrial septum. When you see something like this, then you're definitely sure the opening of the aortic valve is still normal, so it opens quite fine, quite nicely, but there's a difference in the morphology. So this is a tricuspid valve, so the aortic valve is normally tricuspid, and here you only have two cusps. So there's one missing. This is a so-called bicuspid aortic valve. But very important, look at the opening and the closure, so systole and diastole. Also in the parasternal short axis view include a focus view of the aortic valve where you see all the three cusps again, where you can appreciate that the cusps per se here, they are sclerotic. So there's a little bit of calcification, but overall the opening is preserved. So this is definitely or most likely not a severe aortic stenosis because the opening seems preserved. When we take a look now at Erna's case, well, here in the short axis view, it's very hard that you differentiate individual cusps because it's simply just severely calcified. There is probably a little bit of opening left, and if you do not have an optimal view from the parasternal short axis, you can also choose a view from a subcostal approach. This is a subcostal short axis. How do you achieve that view? Well, when you have a 4-chamber view where the marker points to the left side of the patient in a subcostal approach, you simply rotate the transducer and tilt it upwards like you would in a parasternal approach to see the same structure. So here's the aortic valve, here's the interatrial septum, tricuspid valve, right ventricle RVOT, and also here you can nicely see that the valve is severely calcified. Even the calcifications block our field of view in the far field. So this is truly a severely calcified aortic valve. Here's just another example where you see the opening and the closure in the parasternal long axis, how it has to be. So this is distinctly different from what we have seen with our patient Erna. So the normal opening looks like this. So opening in systole and closure in diastole. Moving on to the first Doppler measurement we need besides color Doppler, we need the continuous wave Doppler. We need a 5-chamber view, and we need the continuous wave Doppler at the maximum velocity of the aortic valve. There are some tips and tricks you can utilize to make this easier for you. So first of all, use color Doppler as a guidance. So if you have color Doppler here, you see where is the maximal velocity and where is the region where I have to place the continuous wave Doppler. And if you do that, you can see that there's a signal which exceeds the 4 meters, which would be a severe stenosis, by almost 2 meters. So we are here at a range of 6 meters per second. But if you do not have the optimal signal, and this looks entirely different, you have a less strong signal, and this by far doesn't reach the 6 meters. Still, in this case, it would be around 4 meters, so probably still a severe aortic stenosis. If you do not have the optimal angle or the optimal position of the continuous wave Doppler, you will miss a lot of information. So always try to optimize the image. The second tip is, if you simply move the transducer laterally and tilt the beam inward, the aortic valve will move like a focused right ventricular view towards an optimal alignment of the continuous wave Doppler. Like this, you can even optimize the signal. So the continuous wave Doppler, of course, is a Doppler measurement. It's angle dependent. So if you're off, it leads to underestimation. As mentioned, you can move lateral and tilt inwards to have a better signal, because a good angle equals a good Doppler signal. And in case of, for example, atrial fibrillation, you need repeated measurements to actually display the true velocity of the aortic valve. So in this case, we have a sinus rhythm, and what you can see is this signal is a bit weaker compared to the other two signals. So the most optimal signal is here probably the third one, where you see it's very dense. So this is what you want in an optimal measurement of continuous wave Doppler in the aortic valve. A pitfall I want to mention in this case is the so-called SAM phenomenon. So in this case, we have a hypertrophied ventricle, especially the septum is hypertrophied, the rest looks rather normal. The ejection fraction also looks normal, even on the high normal side. And when you look at the mitral valve, you see that there is a movement, a motion of the anterior mitral valve leaflet towards the LVOT, which is beginning here. So here you already see a beginning of a 5-chamber view. And when you use the continuous wave Doppler here, you see this dagger-shaped signal over here. So that's not an aortic valve signal, so not aortic stenosis, but an LVOT obstruction. So very high gradient, 5 meters per second is the maximum velocity of the signal, but this is distinctly different compared to the aortic valve and the aortic stenosis, of course. And this is a real pitfall, because here you can see there is flow turbulence. So here denoting the flow turbulence and that there is a problem with the outflow, but the aortic valve seen over here and over here seems normal. So the problem is really this movement, this motion, this systolic anterior motion of the anterior mitral valve leaflet towards the interventricular septum, which creates this gradient. So this is a SAM in a hypertrophic obstructive cardiomyopathy. The peak gradient was 107 millimeters of mercury. Here we are talking about the peak gradient in case of a SAM phenomenon or a hypertrophic obstructive cardiomyopathy, because it's hemodynamically relevant or considered hemodynamically relevant when it exceeds 30 millimeters of mercury in rest and 50 millimeters of mercury during exercise. So this was a evaluation during rest. So the peak gradient of 107 millimeters of mercury is truly a high gradient. And there is another pitfall, a so-called pitfall in the pitfall. When you have this gradient, this LVOT signal, and you see it over here in the overall curve visualized here. So this signal would be around 6 meters, a peak gradient of above 122 millimeters of mercury. But there's a problem. This is not the LVOT signal, because you see that there is the LVOT. There is flow turbulence, and you see that the flow turbulence obstructs the LVOT. So the aortic valve seems, at least from this view, fine. We have another problem here. This systolic anterior motion of the mitral valves, of the anterior mitral valve leaflet, creates another pathology, a mitral regurgitation, seen over here. So this is a patient with a hypertensive heart disease, and this narrow LVOT and the thickening of the septum also leads to this SAM phenomenon. So this was not hypertrophic obstructive cardiomyopathy, but due to hypertension in the small ventricle, this gradient was created in a state of hypovolemia. But the problem is, in this case, you have a mitral regurgitation, which is definitely relevant. You can see it here with contrast. With contrast, you see that the LVOT is truly obstructed. So this is the anterior mitral valve leaflet and here the posterior mitral valve leaflet, and you see the anterior mitral valve leaflet always moving towards the septum during systole. And you even see that here is a gap. So this gap, because the posterior mitral valve leaflet is short and compared to the anterior, it cannot cover the rest of the opening. So here you will find the mitral regurgitation as a complication of this LVOT gradient and this systolic anterior motion or movement of the anterior mitral valve leaflet. So here you can differentiate those two signals quite nicely again. So this is the mitral regurgitation signal. I want to go back once more because this is the mitral regurgitation signal. You can see it over here. So this is a measurement of mitral regurgitation. And here you can see it again with the differentiation of the LVOT signal. The LVOT signal with 3 meters per second is still rather high, but it definitely does not exceed 5 or 6 meters as seen over here. So also very often when you have aortic stenosis or a gradient and the gradient exceeds 6 meters per second, then very often you probably measure the mitral regurgitation signal. So always keep that in mind as well. Now let's move on to grading. It's very important to grade aortic stenosis because we already know the measurements when it's normal, but what does a severe stenosis actually mean? Well, in case of a mild aortic stenosis, the aortic valve area is larger than 1.5 square centimeters. The mean pressure gradient, you will calculate that with the continuous wave Doppler signal, is below 20 millimeters of mercury, and the maximum velocity is in between 2.5 to 2.9 meters per second. If you continue to a moderate stenosis, the aortic valve area measured with the VTI is 1.5 to 1.1 square centimeters. The mean pressure gradient is in the range of 20 to 39 millimeters of mercury. The maximum velocity 3 to 3.9 meters per second. And now I want to mention also the aortic valve index, because if you have slim or small or cahectic patients, you should index the aortic valve area. And if you index it with 0.61 to 0.85, it's a moderate stenosis. And furthermore, the dimensionless index should be mentioned, especially in the case of a severe stenosis. In a severe stenosis, if you cannot measure the LVOT properly, because sometimes that simply happens. The LVOT is sometimes very hard to measure. And if you had bad image quality, reduced image quality, maybe you cannot measure it accurately. Always keep in mind that a dimensionless index helps because you simply calculate the LVOT VTI divided by the aortic valve VTI, and the ratio below or equal to 0.25 points towards a severe aortic stenosis. The aortic valve area is below or 1 square centimeter. The mean pressure gradient is above or 40 millimeters of mercury, and also the maximum velocity is above or 4 meters per second. Indexed, it would be below 0.6 square centimeters per square meter body surface area. Then there's another term, a critical aortic stenosis. In a critical aortic stenosis, you have an aortic valve area below 0.6 square meters. And this is now very important. You have a mean pressure gradient, and not the peak gradient, but the mean pressure gradient of even above 60 millimeters of mercury. The maximum velocity will be above 5 meters per second. The aortic valve area indexed is also below or equal to 0.4 square centimeters per square meter, and the dimensionless index is even below 0.2. There's another pitfall I want to point out, and I mentioned it already. It's the poor image quality. In aortic stenosis or with any kind of valvular pathology, you need to have a really full signal. So the entire signal has to have a nice bright spectrum. If that is missing or lacking, the signal is incomplete. Even though now here it is a very high velocity, but still the signal is relatively weak. So that's not optimal. If you have such a signal, and you can also hear that it's not that full, you have to measure again or find a better angulation. Here you also see an incomplete and underestimated signal. Moving on to the pulsed wave Doppler. The pulsed wave Doppler is the second Doppler we need for aortic stenosis. We need it directly placed in the LVOT. Optimally, it is placed where you measured the LVOT, which is very often very difficult. So keep in mind that there is also a certain degree of error in this kind of measurement, simply because you sometimes are a little bit off. How can you optimally place the pulse wave Doppler? Well, place it first in the aortic valve, so in the middle of the stenosis, because then you have a lot of aliasing in the signal, and then move the box, so the pulse wave Doppler measures the velocities in the box, simply back until you do not hear the aortic stenosis anymore. So it's a see and listen. So listen to the signal. When the signal has this darker area below and it looks like this, that's probably the correct LVOT. So always place the pulse wave Doppler first in the center of the stenosis, then you hear this the aliasing and this very, very loud signal, and then it goes back to the LVOT and you hear a distinctly different signal. Also use ECG guidance for the continuous wave Doppler, for the LVOT diameter, and also for the pulsed wave Doppler. And as mentioned, as close as possible, you should measure towards the aortic valve, but really in the LVOT. And you should trace everything from and to the baseline, like the continuous wave Doppler signal as well. Now let's discuss the continuity equation and what we actually found in this patient. For the continuity equation, we need the VTI, so the area under the curve of the signal. So this is the aortic valve signal. The area here is 150.64 centimeters, and this has to be put in this formula. So this is the formula of the aortic valve area, the continuity equation, where you need the cross-sectional area of the LVOT, seen measured over here, the VTI of the LVOT divided by the VTI of the aortic valve. So here is the VTI of the LVOT and here is the VTI of the aortic valve. And when you calculate that, you see that this is truly a severe aortic stenosis, because the measurement shows that the aortic valve area is 0.52 square centimeters. So a very, very small area is left where actually blood flow happens. So this is truly severe, even critical aortic stenosis. Furthermore, you can index it is 0.35 approximately square centimeters per square meter body surface area. And if you look at the maximum velocity, it's above 6 meters. It's 6.21 meters per second. And also if you look at the mean pressure gradient, it's an enormous, a huge number. It's 106 millimeters of mercury. We go back and we remember that severe aortic stenosis begins at a mean pressure gradient of above 40 millimeters of mercury, or 40 millimeters of mercury. So this is truly a very high gradient. So in this case, as mentioned, a severe or even critical aortic stenosis with a maximum velocity of 6.2 meters per second. The aortic valve area is 0.52 square centimeters. Indexed, it is 0.35 square centimeters per square meter. Its body surface area indexed in small and slim patients. She was not cahectic, but she was very slim. The mean pressure gradient, so not the maximum gradient, was 106 millimeters of mercury. And this additional information, the dimensionless index, was also truly severely reduced with 0.14, where the true severe stenosis starts at 0.25. Now, very often you will also get the question, or you want to try planimetry. You can do that in a parasternal short axis or in a parasternal short axis in a subcostal view, but keep in mind that planimetry has plenty of pitfalls. First of all, the actual area you can measure must not be the area which is calculated, because the flow, so the functionality of the valve, sometimes a little bit differs to the anatomy, so it's not always entirely the same. Furthermore, you never know if you're truly at the smallest area which you actually want to measure, or if you're in the correct area. And very often the image quality in such severely calcified valves is simply reduced. But in my point of view, it gives additional information. If you also want to get the feeling for the opening of the valve, you can try to use planimetry and then apply the gradients and the continuity equation, because of course that you have to do to quantify aortic stenosis. But for the look and feel, it's very important to also at least try planimetry. But be aware it's not mentioned in the guidelines because it simply has plenty of pitfalls. Very often in a transesophageal study, it's also easier to see the aortic valve and do a planimetry of the aortic valve area compared to a transthoracic approach. Same holds true, of course, for the mitral valve and mitral stenosis. Very often, from a TTE approach, it's simply very hard to see and to differentiate. One last thing I want to mention is strain imaging. Strain imaging also holds a lot of information or additional information in case of valvular pathology. Here you see that there are some regional problems, so the thickened myocardium leads to a reduced longitudinal strain. Here you see it's relatively preserved. Here you see the curves. Moving on to the 4-chamber view, you can see it here. The ventricle is truly severely hypertrophied. And you see in the areas more basal, the strain is more reduced compared to the areas in the apical regions. You see it over here with the curves as well, where you have the apical regions and the more basal regions. And in the 2-chamber view, the same is seen again, where you have here a reduced strain and here a relatively preserved strain. Here you have the curves again, so every curve you can see the coloring resembles a segment of the myocardium. Here you have the strain M mode, where you see that in the center, also here the color code, in the center where the apical regions, it is more red, and red means normal contraction. So a normal negative value, a normal strain. Overall, this was in the range of minus 12 to minus 15%. When you take a look at the global longitudinal strain at the bullseye, you see that the global strain was minus 13.9%. Also, in case of aortic stenosis, if it is below minus 15%, it's definitely also a hint towards that the patients need an operation or the patients need some kind of valvular replacement. Furthermore, you can see that this strain, for example, did show a certain degree of basal reduction and apical sparing. The apical sparing we do know from amyloid heart disease, and also in this case it gave the information, or at least a hint, that this could be amyloid heart disease. That was ruled out before further treatment of this specific patient. So strain can give also a lot of additional information about other pathologies you might need to think when you are evaluating aortic stenosis. So I want to emphasize again, use strain imaging in case of all valvular pathologies, and furthermore to quantify left ventricular function and to see that in this case the basal reduction in the overall, of course, reduced strain also points towards that this patient needs further treatment, besides the fact that this is already a critical aortic stenosis. Another pathology, or something we need to discuss when we talk about aortic stenosis, is a so-called low flow, low gradient aortic stenosis. It's a severe aortic stenosis we are talking about, and here we have to differentiate the normal from the low. The normal is the ejection fraction above 50, the stroke volume index, that is very important, above 35 milliliters per square meter. This is the formula for the stroke volume, and the mean pressure gradient above or 40 millimeters of mercury, and of course the aortic valve area, which is below or 1 square centimeter. Talking about the low flow and low gradient situation, you have definitely a reduced ejection fraction, a reduced, and that's important, stroke volume index. So you calculate that from the LVOT signal, it is below or 35 milliliters per square meter. So it is below 35 milliliters per square meter body surface area, so that's the low flow. And the mean pressure gradient is below 40 millimeters of mercury, that's then the low gradient. And the aortic valve area, which doesn't fit the other findings, especially the mean pressure gradient, is below or 1 square centimeter. So that's a paradox, because there is low flow and the aortic valve area is very small, but the gradient cannot be achieved. So we're in a situation where we have to think further. How can we evaluate those patients in case of a low flow, low gradient aortic stenosis? Here you can see again a low ejection fraction, this is probably 35%, and a reduced left ventricular function, of course, and the stroke volume index was here below 35 milliliters per square meter. When we evaluate the continuous wave Doppler signal seen over here, we get a mean pressure gradient of 26 millimeters of mercury and an aortic valve area which shows a severe aortic stenosis below 0.85 square centimeters. So the mean pressure gradient shows that this is not severe aortic stenosis. The aortic valve area says that it is severe aortic stenosis. What can we do? Well, we can apply low-dose Dobutamin stress echo. In this low flow situation where the stroke volume index is below 35 milliliters per square meter with a low gradient and a very small remaining surface of the aortic valve area, we use low-dose Dobutamin up to 20 microgram per kilogram per minute to prove if the aortic valve area is truly below 1 square centimeter when we have a normal flow. So the stroke volume index has to be above 35 milliliters per square meter and the mean pressure gradient should be above 40 millimeters of mercury. So we need to see if there is also a contractile reserve in this case. And for the patient before, we do see that with a low dose Dobutamin, the mean pressure gradient did rise above 40 millimeters of mercury, where the aortic valve area still was below 1 square centimeter, which means that this is a true severe aortic stenosis. What about the situation where you have severe versus pseudo-severe aortic stenosis? This is another term you have to remember in case of the evaluation of aortic stenosis. In this specific example, we have reduced left ventricular function, we have a left bundle branch block, again in the range of probably 30-35% ejection fraction, probably here also wall motion abnormalities, but definitely reduced ejection fraction. Well, in this signal, we do see this is an optimal signal. We have a maximum velocity of 3.9 meters per second. We have a mean pressure gradient of 31 millimeters of mercury, but the aortic valve area was below 1 square centimeter. So we did use low-dose Dobutamin, and in this evaluation of low-dose Dobutamin, here you can see the 20 microgram per kilogram per minute. You see that the pulse wave Doppler signal and the measurement of the pulse wave Doppler signal shows that you have a stroke volume index of 55 milliliters per square meter. So this is a normal flow, so this patient has a contractile reserve, and the aortic valve area, if you take a look over here, is above 1 square centimeter, so 1.26 square centimeters. So this is a pseudo-severe aortic stenosis. So in rest, the patient has an aortic valve area below 1 square centimeter, but with the stress echo, we force the ventricle to show that it has contractile reserve, and the aortic valve area now is in the range of a moderate aortic stenosis. So with low-dose Dobutamin stress echo, you can differentiate in between a true severe aortic stenosis or a pseudo-severe aortic stenosis. Moving on to another disease entity, the so-called paradox low-flow, low-gradient aortic stenosis. Why paradox? Well, in this case, you do see that the ventricle is relatively small and left ventricular function is good. So it's probably even in the high normal range of 60% or 55 to 60%. And you do see that the aortic valve is severely calcified. And in this case, you also have a stroke volume index which is below 35 milliliters per square meter and a mean pressure gradient not exceeding 40 millimeters of mercury. And in this case, you have an aortic valve area in this paradox low flow situation because the ejection fraction is good, but the flow is still reduced, of 0.62 square centimeters. What can you do in this situation? Well, you have two choices. You can also use a stress echo, as we did in this patient, for example. We started with an aortic valve area of 0.76 square centimeters, a mean pressure gradient of just 20 millimeters of mercury, and a reduced stroke volume index with 22 milliliters per square meter. During stress echo, you can see it here, we did measure with 20 microgram of Dobutamin per square meter per minute. We did see that the stroke volume index definitely improved to 34 milliliters per square meter. You can see here the supernormal ejection fraction and the aortic valve area also improved. So this is again moderate stenosis with 1.17 square centimeters. So this is again a pseudo-severe paradox low flow, low gradient aortic stenosis. If you do not have stress echo at hand, or if you also want to follow the guidelines, you can use a CT scan of the coronaries and the calcium scoring to differentiate if it is most likely a severe aortic stenosis and needs some kind of further treatment. Now let's go to the guidelines. What does the newest guidelines of 2021 tell us about the valve morphology with echocardiography suspicious of aortic stenosis? Well, of course, initially we have to assess the gradients. If we go to the right side and we have a high gradient aortic stenosis with a high flow velocity of 4 meters per second and a mean pressure gradient of above or 40 millimeters of mercury and a normal flow status, we have a true severe aortic stenosis. If we do have a high flow status, we have to think about how to reverse it. Going to the left side, we see that there is a low gradient aortic stenosis with a gradient below 40 millimeters of mercury and a maximum velocity below 4 meters per second. And we have an aortic valve area below or 1 square centimeter, we need to move on. If the aortic valve area is above 1 square centimeters, and that's rather important, you can call it a moderate aortic stenosis. So if all the measurements fit and the gradient is below 40 and the aortic valve area is 1.2 square centimeters, for example, it is really a true moderate aortic stenosis. If it is below, we have to check the blood pressure, and in our echo lab we always try to measure the blood pressure also in a routine exam, especially when we do stress echo, of course, that we have to, but in this case the blood pressure is important to exclude measurement errors. If you have a normal blood pressure, you have to define the flow state. So is there low flow, so stroke volume index below or 35 milliliters per square meters? Or is there a normal flow, so above 35 milliliters per square meter? Continuing, we stick to the left side initially. If we have a low flow in the region below 35 milliliters per square meters, but a normal ejection fraction of above or 50%, we should go the integrated approach where we need the calcium scoring and the CT scan. If we go back here and have a normal flow, so above 35 milliliters per square meter, we also can say this is a truly severe aortic stenosis, so we do not need a further workup. In this situation, as we discussed before, when you have this low flow and a low ejection fraction, so below 50%, we need to see if there is flow reserve, so contractility reserve. And if it is not present, so even with stress echocardiography, we do not see a rise in the gradients, we also go to the CT scan. If we have a flow reserve and it is aortic valve area below 1 square centimeter throughout the stress echo, we go for the true severe aortic stenosis. If the aortic valve area improves and it is above 1 square centimeters, we have this pseudo-severe aortic stenosis. Here you see the overview of the guidelines. You can check out this graph and all the measurements as well in the guidelines. It's a very nice paper to read from the ESC of 2021. Now, we talked about the hyperdynamic state. What is a hyperdynamic state? First of all, if you have a relevant aortic regurgitation, because there's a volume shift. So you have the flow through the valve, but also the backflow, which leads to this hyperdynamic state because of the volume overload, because there is relevant aortic regurgitation. If you have fever, or if there's a patient who is septic with anemia, hyperthyreosis, pregnancy, all those reasons can lead to a hyperdynamic state. And before you evaluate aortic valve stenosis, there shouldn't be a hyperdynamic state because it could lead to overestimation of the gradients and the severity of the aortic valve. Now, something which is very often asked, and it's very important, how to actually write a report. First of all, describe the valve with the morphological findings. Is it tricuspid, bicuspid, even unicuspid or quadricuspid? Describe the valve and the valve borders. Are they smooth? Are they sclerotic? Are they mild, moderately, severely calcified? Describe the opening. Is it preserved? Is it reduced? Measure the gradients and grade the stenosis. Also includes the LVOT diameter and the stroke volume index in your report, because everyone else can see what you measured and adapt it in their own measurements if they are not sure to have a reassurance if they are measuring correctly. And then if the aortic valve area is below 1 square centimeters in case of a normal ejection fraction with a mean pressure gradient below 40 millimeters of mercury, always go back and reevaluate. So measure especially the LVOT simply again. So it has to be in the range of 20 millimeters. So everything in between 80 to 22 is probably normal. If it is below 18 millimeters, the patient has to be rather small and slim. If it is a large patient, of course, it can exceed 22 millimeters. So also 24 millimeters, 25 millimeters can be seen. But if you have, for example, a large male patient, he is 2 meters in height, and you have an LVOT of 14 millimeters, definitely something is off. So always compare the LVOT with the person you're actually scanning and adjust it to the body surface area, what the most likely measurement will be. If you have a mean pressure gradient below 20 millimeters of mercury, that practically rules out a severe aortic stenosis. So if you have a mean pressure gradient below 20 millimeters of mercury and still measurements are off, go again back to measuring the LVOT. Very often the LVOT is truly the problem. And I want to emphasize again, as we have seen in Erna, this is a severely hypertrophied ventricle. We did think about amyloidosis, especially with the additional information of strain imaging, also showing that the global longitudinal strain is definitely reduced. There was no amyloidosis present, but still strain imaging gives a lot of additional information and should be part of this exam. We will continue with more valvular pathologies and with the compact echo course in the next lectures.